Dr. Selma Chiesa-Fuxent, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's educational activity entitled Accurate Diagnosis, Evidence-Based Treatment, and Long-Term Management in Persons of Color with Atopic Dermatitis. Today's program is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals. Today's activity is brought to you by CME Outfitters, jointly accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on slides, and answer polling questions, and send us your questions. Please don't wait until the end to answer or ask your questions. Dr. Heath and I will be addressing them throughout the webcast. And as I mentioned in the beginning, I'm Selma Chiesa-Fuxent, and I'm an assistant professor of dermatology at the University of Pennsylvania Perelman School of Medicine. And I'm very happy to welcome today my colleague, Dr. Candace Heath. Dr. Heath is an assistant professor of dermatology at the Lewis Katz School of Medicine at Temple University in Philadelphia. So welcome, Candace, and thank you so much for joining me today.
Thank you so much for having me.
And now let's begin with the reason we are all here, which is our patients. So prior to the program, CME Outfitters surveyed patients with atopic dermatitis to better understand their treatment journey. So let's begin today by hearing their patient experience.
Due to the color of my skin, I am Latina and I have darker skin. I think that there was some initial maybe misdiagnosis as to what was going on. They thought maybe dry skin, and this was through my general practitioner. It was not until I went to the dermatologist that they were able to give me an accurate description.
I do not feel like my dermatologist or primary care physicians over the years have been skilled in diagnosing skin disorders in persons of color. I don't think that they get adequate education in medical school, and continuing education is lacking in how these issues present on darker skin for persons of color.
Great. So Candace, from our experience treating patients with skin of color, I think these audio clips are really not surprising. We have changing demographics in the United States that underscore the importance of this change in dynamic. So can you talk to us a little bit about how our country is changing?
Oh, absolutely. You can see based on the graphic that is posted for everyone to see just how diverse our country is becoming. So the darker green means that that area is becoming more and more diverse. And interestingly, the U.S. Census really reported in 2020 that children in the United States who had skin of color outnumbered those who did not. So we are definitely growing and becoming more diverse.
I see.
And although our nation is becoming more diverse, we actually have to catch up on our education. So that's why important programs like tonight is very, very important. So for an example, when we think about dermatology training, this is what this slide is really focused on, is talking about education. How do we train physicians in dermatology to take care of those with skin of color? In this particular study that is highlighted here, what it shows is that even people who are training to be dermatologists really may not have access to learning from skin of color experts. So not only do we need more help in dermatology, every physician needs to really be invested in learning more about skin of color. And as you can see, the specific study that they're highlighting showed that people in the training program said, yes, we also don't have enough access to experts in skin of color. But the great news is that we are getting more and more skin of color specific centers all across the United States. So hopefully we can close that gap. And as we turn now, we're going to talk more specifically about atopic dermatitis. That's going to be our focus for the next a few minutes, just giving you some background stats to really kind of help you understand why this is such a huge importance in skin of color. In pediatric patients in general, about 20% have atopic dermatitis, and in the adult population, about 10% have atopic dermatitis. But the population that is most affected by atopic dermatitis are our Black children. So they are also not only more likely to have atopic dermatitis, but importantly, more likely to not have the proper treatment, more likely to have treatment-resistant disease as well. So it's definitely something that is important, and I'm happy that we are talking about this today. And in addition to the patients of color having more advanced disease, also there are comorbidities and other health disparities, which we will talk about, that really can impact this population. So Velma, I know that you know about the burden of atopic dermatitis, but there's also a psychosocial burden as well. So I look forward to diving into that. So oh yes, go ahead.
Now, I just wanted to make a comment on that note when we're talking about the psychosocial burden of atopic dermatitis. You're absolutely right. It's disease that's associated with many comorbidities, but as you'll likely explain in this slide, it's also associated with a very high psychosocial burden, which could be very important in our patients with skin of color because of the impact it has on them on a daily basis.
Absolutely. I totally agree. And particularly in patients with skin of color, post-inflammatory hyperpigmentation is definitely a huge problem. When they studied and looked at the quality of life with patients who have pigmentation issues, post-inflammatory hyperpigmentation cases actually impact quality of life more than other forms of hyperpigmentation. And also, multiple studies have been done that show that adults with atopic dermatitis are more likely to have depression and anxiety and even suicide attempts or suicidal ideation. So atopic dermatitis is definitely an important disease to recognize, and recognize all the comorbidities that are associated with it.
You're right, Candace. And when we talk about disparities, right, in healthcare, can you comment about some of the disparities in pediatric atopic dermatitis care?
Absolutely. And this is one of the reasons I'm so excited to participate in this program today. We need everyone to be on deck and to really help. So when they have done studies that looked at Black and Hispanic children with atopic dermatitis, they found that they had more primary care visits and more emergency room visits for their atopic dermatitis, and they were more likely to miss school and other activities because of it. But interestingly, they were the least likely to actually see a dermatologist and to have poorly controlled atopic dermatitis and less likely to see a dermatologist. So that is definitely something that is important that we all can help with. And I'm going to dive even deeper in the next slide to really bring this point home. So in this study by Tackett et al., they looked at various parameters when it came to socioeconomic risk factors and moderate to severe atopic dermatitis. So I would like to highlight 5 points from that important study. They looked at a large database, and they looked at the number, the odds ratio, and they looked at the number of children who came from families earning less than $30,000 per year. So in their sample, Black children and Latinx children were more likely to live in a family with making less than $30,000 per year. When they looked at the education of the caregivers in the home, when they said, okay, what group has the most parents that has less than a high school diploma. That, with that stat, the Latinx children definitely took the highest ranking on that. So they are more likely to have parents that did not finish high school. When it came to smoking, Black children were more likely to live in a home where there was one or more smokers. When it comes to living between two different homes, the Black children were way more likely to live between two homes. And when it came to rented homes, Black children were far more likely to live in a rented home than the other groups.
Thank you, Candace. I think it's important that these types of studies are being done because we do know that the pathogenesis of atopic dermatitis is quite complex, and there's multiple genetics, inflammatory, but also environmental factors where we could potentially intervene and help improve our patients' overall health. So let's move on to our first learning objective, which is how can we integrate tools for the assessment of atopic dermatitis in patients with skin of color. And so we're going to frame our discussion today using a pediatric and an adult case that may be representative of some of the patients that you might be seeing in your practice. So let's move on to our first case. And then Candace, can you present Braden to us?
Yes, let's dive into Braden's case. So this is an 8-year-old boy who's had atopic dermatitis since he was a baby. And over the years, it's becoming progressively more difficult to treat as he's gotten older. The itching definitely affects his sleep. It's begun to actually affect his school performance as well. He does have seasonal allergies, which peaked a little later in the season than in the years past. And he recently moved to a new rental apartment that has carpet. And he in his home is not exposed to smoking or pets. When we think about the clinical involvement of the skin in Braden, he has involvement of his atopic dermatitis in the flexor surfaces of the antecubital fossa, on the arms, and also on the legs as well. He has more papular lesions. And also follicular prominence of the skin is also present. And a total body surface area of involvement is around 30%. So it's quiz time. It's quiz time. So this is one of your opportunities to participate and get involved. So our first question is, how would you characterize Braden's atopic dermatitis disease severity? And we will give you some time to put in your answer. Okay, all right. So the majority of you answered that this is a moderate case of atopic dermatitis. And then behind that, the next thing that was selected was severe. So I think that our audience tonight, Zelma, is right on target with what's going on with Braden's skin. Do you agree? Do you not agree? What do you think?
No, I agree. I think that this is a patient that will fall in that spectrum of patients with moderate to severe disease. And I think when you look at the impact that this disease is having on this child to the point where he's not sleeping well, right, which can lead to difficulties in concentration, I think those things are important to acknowledge. And oftentimes we may not be asking those questions in clinic, and we may not be making the right assessment in terms of disease severity. So I would agree with our audience.
Okay, I do as well. So now that we've spoken about Braden, Zelma, are you able to present our adult case of atopic dermatitis?
Of course, Kendra. So let's talk a little bit about Cecily. So Cecily is a 27-year-old woman who has had atopic dermatitis since she was a child. It's over the year, it's been coming and going, with times being a little bit better than others. She's treated in the past very successfully with topical corticosteroids and the use of emollients or moisturizers as part of her basic skincare regimen. But she was recently referred to a dermatologist following a very resistant flare that would not seem to clear up. And now she's coming in with development of what she's calling these dark patches that she refers to as scars on her face that cause her to be very self-conscious about her appearance. Now, to our audience, this is another opportunity for you to participate. What would be your diagnosis for Cecily in terms of her clinical presentation? Okay, so let's see here. From looking at our audience response, Candace, are you able to see the responses or your end?
Yes, I can see them. So about 61% of our audience selected choice number 4, which was post-inflammatory hyperpigmentation. And the next in line was 18%, which was for selection number 1, progression of the atopic dermatitis flare. But I think the audience definitely recognized that number 4, 61% post-inflammatory hyperpigmentation was the most common response.
That's excellent. Thank you for sharing that, Candace. And I think it's important to pause here and discuss those results for a second, because this is a very common scenario that we see in clinic, right? We have a patient that's coming in with what looks like an exacerbation of they report it as an exacerbation of their eczema, but the atopic eczema is just not getting better. And they come in and they use the word scars. My skin is now scarred, right? And so we have to take the time to educate our patients that this is not what we consider a true scar, that this is a condition called post-inflammatory hyperpigmentation, which we will see later on, tends to be more prevalent or probably result in more burden in our patients with skin of color. And so from going back on these two cases, I think it's important to recognize that there are certain things that are common for both, right? In both cases, you want to make sure that we do have an accurate diagnosis, that we rate the severity of the disease appropriately, and that we begin to understand that there may be some differences in terms of the properties of Black skin compared to white skin, right? We do know that, for example, patients who have darker skin types tend to have more increase in the transepidermal water loss, which can then lead to more dryness of the skin. We also talk about filaggrin, right? Mutations, which is probably the strongest genetic component in atopic dermatitis. But if you look at the studies on filaggrin, most of the studies have been primarily done in those of European descent, not so much in Black patients. And so what we see from the few studies that are available is that certain filaggrin variants are present, but this may be different than in our white counterparts. So there are certain differences there that we need to acknowledge. And so, Candace, when we talk about atopic dermatitis, we know that this can present very differently in patients in skin of color. And so we do have a couple of questions from the audience. So we're probably going to address that in a second. So thank you to the audience member for those questions. I'll get to those in a minute. But Candace, going back to you, can you help us differentiate atopic dermatitis in patients of skin of color for us?
Absolutely. I love talking about this topic because I think it's so helpful just to recognize a few key differences. So one of the first things is that you may not ever see erythema or redness depending on the person's skin tone. So the darker the skin tone, you may not be able to appreciate redness or erythema at all. And then in some patients, they may have more of a violaceous hue to their skin. And then others may just have more subtle darkening of the skin as well. So that's really, the first thing. You may not see red. Number 2 is about a different type of presentation. And we heard a little bit about this when I presented Braden's case, but there is more likely to be more papulation or raised bumps on the skin or raised papules on the skin. They can occur in groups sometimes. And also, you're more likely to see lichenification, which is thickening of the skin with accentuated skin markings in those with skin of color. And it can often affect the extensor surfaces. And thirdly, we also want to stress again about the erythema that you may not see, that may be more common in patients with white skin. And then also I wanted to point out that changes in pigmentation can also occur. So for some patients, when their condition becomes more flared, you may see more hyperpigmentation in active areas. And in other patients, the opposite may occur. They may actually get hypopigmentation. And I take care of a lot of children, and that is definitely one of the more common things that I see in some patients with skin of color, to actually start to get light patches as well.
And Candace, I really do want to take a minute to answer a couple of questions from our audience. So we do have a question about how we talk about differences between white and black skin, but are there any significant differences related to brown and black skin in the presentation of AD? So can you comment on your experience with respect to that?
Sure. So there are all different shades of brown. And when we're talking about going from brown skin to very, very darker skin type, then you are definitely going to lose that erythema that we talked about. So in a very dark skin type, you are really going to just see that more purpley, violaceous color, or none at all. So you really have to be on your P's and Q's when you're suspecting atopic dermatitis in someone with very, very dark skin, because like I said before, you may just get either more darkening or a violaceous hue. But then you're still going to see all of those other manifestations, the papular form. You're going to see lichenification still. That doesn't change just because the patient's skin is darker. It is really that erythema look that you're definitely going to have to kind of cross off your list, because you may not see it in the darkest skin tone.
Right. And there's also another question about white skin scarring. And I wonder if this is referring to the hypopigmentation that we can sometimes see in lighter skin tones. Can you comment on that as well?
Sure, and I think that we should have added some slides talking about scarring alone, right? So as Delma pointed out earlier, this term scarring means so many different things to so many people. So in a patient with more of a fair skin tone or more lighter skin tone, they may refer to scars just as a persistent erythema or redness on the skin. So the area may not necessarily be itchy at that time, but if it has some area of sustained redness, they may actually identify that and call that a scar. So you always have to ask more questions. So if a patient is mentioning scarring, then you want to definitely follow up with some key questions, and you should be able to do that after listening to this program. Well, does it itch? Do you not like the way it looks? Tell me how it feels. Tell me more about that, so that you can kind of delineate out exactly what they are talking about. But I think that's a great question. A great question. I'm glad someone asked that as well.
Okay, and then when we talk a little bit more about post-inflammatory hyperpigmentation, and there's a question from our audience about what are our go-to measures, but I want to just talk a little bit about that in the following slide. And post-inflammatory hyperpigmentation, as we had previously mentioned, is perhaps one of the top 5 chief complaints that we will see in our patients with skin of color. And we know that it's not just a disease of the skin, that it has an impact on our patients' quality of life. We don't really understand the mechanism as to why post-inflammatory hyperpigmentation or PIH occurs, but we know it can be related to an increase in melanocyte density, hyperplasia, and also hypertrophy of the skin. And it tends to be more persistent and clinically visible in darker skin tones, and it's often confused with erythema or redness. Can you comment a little bit of what are your go-to measures? And I think we'll talk about that a little bit later, but if you want to just throw something out there for our audience, and we can get back to that later on.
Oh, yeah, sure. So when thinking about go-to measures, I definitely do like to ask about the actual itch associated with the eczema and sleep disturbance. So we'll get into the details of what those measurements are. But if we go to the next slide, I can also kind of dive even deeper into one of the ways that some of the systems we have to describe and track atopic dermatitis are a little bit flawed. So I'm glad that we are talking about that and people are really in tune about diagnosing and redness and whether it's present or not. So let's dive a little bit deeper into this whole erythema and color red problem. So some of the measures that are used to say whether the person is flaring, they have active disease, are they getting better? Some of those scores actually include points for erythema. But what do we know now after listening to this program? You may not see erythema, particularly in those with skin of color. So there is an assessment that's often used, sometimes in, definitely a lot in research studies, as well as some people use it at the point of care as well. Steroids is one of them that uses redness as a measure. So you can imagine if that tool that people are using that's verified to determine whether the patient is getting better or worse, we may not be getting an accurate picture when it comes to patients with skin of color. Also, there are some scales that really focus on patient-related outcomes. And guess what? Some of those also include erythema or redness as a measure when you're scoring. So when you have someone with brown skin, you definitely, we think about what we talked about in the beginning, more likely to have a more severe disease. So a study has really kind of talked about this problem and this flaw with measuring erythema and using it for these particular types of rating scales and said, hey, we should probably be adjusting for erythema or the lack of erythema in patients with skin of color. And of course, you know that I totally agree with that as well. And then one of my tips when you're really trying to figure out, is the patient red? Do they have any kind of underlying erythema? One of the things that I like to teach is to find a normal looking area of the skin. And you can look at the normal skin and then look at the affected area and back at the normal skin and the affected area. You can kind of begin to train your eye to see if you see any hints of erythema or violaceous hue. So that's one of my tips. And so I will challenge you to kind of use that this week with patients that you're seeing to see if indeed either you're missing the erythema or is it just really not visible at all. So we're going to dive a little bit deeper into some of these assessments that I mentioned before. So there are some measures of disease severity, and all of these have little abbreviations, right? You mean, of course, it wouldn't be medicine without abbreviations, right? So we have the SCORAD, which talks about is a reflection of disease severity, which can also include some indexes about erythema. The EASY score is another one that's used. And then the overall Investigator's Global Assessment is another way to measure disease severity in atopic dermatitis. And then, of course, quality of life measures, hugely important. We already talked about why. So there are some validated scales for that in dermatology. So the Dermatology Life Quality Index, and they also have a pediatric version of that as well to measure kids' quality of life. There are some symptom-specific scales that you can use. The POEM scale, I think that is one that Zelma loves to use with her patients as well. It's the patient-oriented eczema measure. There's also the PPNRX, which focuses more on itching, includes things about itching and sleep. And then for mental health, there are measures for mental health that we can also do on our patients as well that really assesses that anxiety, the depression, those other comorbidities that we discussed. So, of course, it would be cumbersome to do all of these scales on your patients, but the take-home point is that if you look at a scale that you really like and you want to begin incorporating it, these are some places to start exploring that option. So when we talk about using the scale, you can decide, okay, do I really want to know more about whether they're having a lot of flares or not? So if that's one of your go-to questions, then here's an example of one of the scales, some of the scales that may be appropriate for that. You can use a SCORAD, the poem, the IGA reading. If you are interested in how the atopic derm is affecting their mood, you have specific scales for that as well. The NRS, the scale that I mentioned in the last slide, which talks about itching, it really focuses on what that patient's life was like for the last 24 hours. Because we know that sometimes our patient memories are a little bit scattered, so they may not remember what happened a month ago, but they can definitely tell you what the state of their skin is in the last 24 hours. And then also, this is important, are you experiencing pain in your skin? That's definitely something that's underrated that we should definitely ask patients more about. And you'll be surprised when you start asking how many patients have atopic dermatitis admit to having skin pain. And then, of course, quality of life. It can be measured in the DLQI and others as well.
Thank you for this great summary, Candace. Before we move on to our next learning objective, we do have a couple of great audience questions. So there's one question about, what is your go-to measure for disease severity? Something that would be easy to calculate without actually having to calculate, right? And I think that's very important. If you're in a very busy clinical practice, it might be difficult to do something like such as the EASY or the SCORAD. My experience has been that you could use something like the POEM score. There's still some calculation involved there, but I think the benefit of the patient-oriented eczema measure is that, first of all, it's something that's available that you can download for use in your clinical practice, right? It's a sheet, you can actually print it, give it to your patient while they're in the waiting room, or have your nurse help the patient fill it out while you're waiting to go in and see the patient. And I will particularly use the POEM score because it does capture the patient experience during the past week. So it gives me a sense of how they've been doing, right? And it will ask about symptoms related to the impact of atopic dermatitis on sleep. It will ask about bleeding, itch, dryness. So there's certain elements of the poem that I find it's useful for clinical practice. It's important to know that it's not really been validated in that setting. It's mostly used in clinical trials, but it's one option for you to use. Another measure that you could sometimes incorporate is the Investigator Global Assessment that hasn't really also been validated, but you can select a number from 0 to 4 that goes from clear to severe disease, and you can capture that as part of your visit. And if you have the energy and the time, you could consider incorporating EASY. But at least in my daily practice, I will more consistently use the POEM score above other measures, but I will also ask about certain symptom specific, right? So you mentioned pain, it's probably underreported. So I will ask my patients, are you in any pain? From 0 to 10, how would you rate this? The same for itch, from 0 to 10. What's your average itch in the past 24 hours? What's the worst it's been in the past 24 hours? And I also ask about symptoms of depression or anxiety, not using a specific scale, but I often find that, as we talked about, this is a huge burden in our patient population, and symptoms of depression and anxiety are something that a patient will not really volunteer unless we ask them. But do you have any specific measures, Candace, that you use in your clinical practice?
I typically would use the Investigator Global Assessment because it is quick, and then also adding the body surface area of involvement as well is another measure. So those are some of my go-tos.
Okay, and then there's one question going back to the erythema. So someone is asking the question about, do you have any particular tips for picking up erythema over telehealth, which is our changing reality, right? As we see patients in telehealth, at least our experience has been that we try to coach the patient to kind of adjust the lighting a certain way and take the photograph from various angles. But the lighting, I find, is what seems to be most important. In your experience, Candace, any advice for telehealth?
Yes, I do telehealth every week. So one of my tips, okay, I've tried lots of things, but this is what I tell them. I say, find a window. And I will actually look at them, and I can see light coming from one side. So sometimes I will tell them, turn your body and the camera, computer, everything to that side. Or I will tell them to find a window, and I want them to face the window. Now, 9 times out of 10, they usually put their back to the window, but at least they're in position and I can just tell them to turn around. That is the easiest way that I have found to have the proper lighting to be able to identify erythema or not.
Perfect. Thank you, Kendra. So let's move on to talk about management of atopic dermatitis, which is our second learning objective. So let's go back to Braden and Cecily, our patient cases. So Kendra, can you talk again, summarize just very briefly Braden's case?
Yes, so we talked about Braden before, but I'm going to just review some of the highlights of Braden. So remember, he had some involvement of the flexor surfaces of the right antecubital fossa on his arm. And then he also had both legs involved with more papular lesions, follicular prominence, and we shared that the body surface area of involvement was about 30% for Braden. So now we're going to ask you to get involved and participate in our next poll. So the question is, what would be your treatment choice for Braden? What would be your treatment choice for Braden? The first option is crisaborole. The second is tacrolimus and topical steroids. The third option is systemic therapy, including methotrexate, azathioprine, thiopurine, mycophenolate mofetil, corticosteroids. The next option, phototherapy. Next option, dupilumab. Next option, I'm not sure. Oh, I love the music.
So going back to Cecily, and I think it's important that we again summarize, this is a patient that has had long-standing atopic dermatitis that she's tried to manage with topical corticosteroids with varying responses, and is now coming back because she has these quote unquote scars on her skin that make her very self-conscious. And so I think it's wonderful. Let's move on to the next, that we do have an audience question, but let's go back to the audience response first. So again, what would be your treatment choice for Cecily? So to our audience, please select what you think would be the best or most appropriate choice. Okay, so we are going to come back to those results again later at the end of the program. Now we're going to be moving forward with how do we treat patients with atopic dermatitis, right? And it's wonderful because we can bring you both the adult and the pediatric perspective. There was a question here as to whether or not do you treat them the same, do you treat them differently? And I think, you know, at the get-go, I think what's most important is establishing the correct diagnosis. And your differential diagnosis, if you're talking about a pediatric patient versus an adult patient, is probably going to be quite different, right? With the pediatric patient, you might be thinking of atopic dermatitis, seborrheic dermatitis, contact dermatitis. If it's a very young patient, you know, almost at birth, is there a nutritional deficiency? Maybe is there a genetic, you know, disorder that we need to identify versus a patient that's older, more adult onset atopic dermatitis? You might be thinking of things also contact dermatitis, but maybe psoriasis and a typical presentation of psoriasis, maybe cutaneous T-cell lymphoma. So it's important that, you know, the first thing is having that, establishing the correct diagnosis, okay? And understanding that the differential diagnosis can be quite different between both groups. I think in my experience, Candace, you know, from the get-go, what forms the foundation of skin, you know, in atopic dermatitis is carries a basic skincare regimen. Everyone starts off with that, right? No matter where you are in the severity spectrum, that is a very important part of your skincare that skincare regimen is a very important part of your treatment. And so when a patient comes to me and I'm thinking about, okay, you know, this patient is presenting with an acute flare, how do I treat these patients? And I treat them thinking about, first, I want to control those acute flares as quickly as possible, right? And as effectively as possible because my patient needs relief. Second, what am I going to be doing long term, right? We could maybe be using a course of oral prednisone to calm it down, but that's probably not the best idea in the long run, right? And we might need to think about potentially adding other things, particularly in those patients with a moderate to severe disease. And then the third thing that I think about is, patient preference, right? It doesn't matter what I want, it's what the patient wants at the end of the day, right? It's a process of shared decision making. And my patient and myself, we both have to be on board. Otherwise, there could be poor adherence to treatment, and that may be misconstrued as the treatment is not working. So how do we step up, our treatment in patients with moderate to severe atopic dermatitis? When is the time to take that step forward? And so typically, if I have a patient who comes to me and says, you know what, I've been using topical steroids on and off for so many years, they just really do not control my disease, or I have to be constantly using them in order to achieve good disease control and I'm still flaring, that's probably the patient that you're going to want to move forward with. Or if a patient is having such high burden from their disease that they're telling you, I cannot sleep, I can't function at work or at school, I'm having difficulty enjoying the things that I like, those are probably the patients that need more of an intervention. And we should think about moving in direction either phototherapy or systemic therapies. With phototherapy, I think it's important to recognize that it's becoming increasingly difficult to find phototherapy centers close to our patients. And there may be a long distance to travel. Patients may not have flexible, working schedules. There may also be high copays, or they might simply just not tolerate it being inside the machine, right? So for a patient where phototherapy is not advisable, and we might be thinking about systemic agents, then you do have the option of doing either oral medications or injectable medications. And it really will depend at the end of the day, what are your patient's characteristics, how quickly you need disease control, what is the patient preference, do they prefer something orally versus injectable, and what are the side effects associated with this treatment. I think it's important to know that, the systemic medications that are out there, cyclosporine and methotrexate are probably the ones that I will tend to use mostly. They're off-label, right? Not really approved by the FDA. And that was more so prior to the approval of Dupilumab, which is biologic for patients with atopic dermatitis with moderate to severe disease that's not very well controlled. So, before Dupilumab became available, my go-tos would be primarily cyclosporine or methotrexate. But now that we have the option of Dupilumab, I find myself prescribing this more as a first-line option. Candace, can you mention a little bit if your experience treating moderate to severe is a little bit different, or what other tips you have?
I totally agree. Definitely, after the approval of Dupilumab, that definitely changed my step therapy for patients. So for patients who were moderate to severe, I definitely would move to that more quickly than I would have some of the other medications that can be immunosuppressive. So it definitely has changed my approach to atopic dermatitis in the last several years.
That's great. And then when we talk about, we've been talking about differences in the presentation of atopic dermatitis and disparities in AD treatment. I think it's important to know, that Dupilumab, has been around for a while now. But it's interesting to see that Black adults with atopic dermatitis had been shown to be less likely than white adults to be treated with non-steroidal options or options such as Dupilumab, as you can see here represented by the left bar graph. And so that raises questions to me about, is it that we're not really recognizing the erythema and then we're sort of kind of not really assessing the true severity of the disease? Is it that there is a barrier to care in terms of being able to see the dermatologist sooner? So those are things to consider, that those disparities are still out there. So now let's talk a little bit about the safety and efficacy in skin of color in patients who are being treated with Dupilumab, right? And it's important to recognize, there's actually, I think, an effort to be more conscious about the number of people that are enrolled in clinical trials and the diversity of patients that are enrolled. Most of these trials, when looking back many years back, it would primarily be white patients, that we really wouldn't get the full spectrum of all our patients. This was actually a very interesting study that was published in the Journal of Drugs and Dermatology, looking at the safety and efficacy of Dupilumab across different races. And then what this study showed was that dupilumab was actually particularly helpful across the spectrum, right? Resulting in improved endpoints in EASI, or the Eczema Area Severity Index. It improves pruritus or itching, and also resulted in improvements in quality of life, also being very well tolerated and acceptable across subgroups of patients. Now, Candace, when talking about younger children, can you talk a little bit about some of the new data that has been released in school-age children for dupilumab?
Sure. There was a recent study that was a 16-week phase 3 trial where dupilumab and standard of care was compared to topical corticosteroid use alone. And they evaluated things such as overall disease severity, improved skin clearance, itching, and also health-related quality of life. So what they found in the 16-week phase 3 trial was that 28% of the group that became clear or almost clear were using the dupilumab versus 4% who were using topical corticosteroids alone. 53% of the participants who were using the dupilumab and standard of care topical steroids achieved greater than 75% overall baseline disease improvement, as compared to 11% with just using topical steroids alone, and 70% of the dupilumab group versus 20% in the topical steroid only group had improvement from baseline in overall disease. And when they looked specifically at itching, 49% of the children who were using the dupilumab and standard of care topical corticosteroids versus 2% in the group that only used topical corticosteroids had improvement in their itching. So these were some of the major take-home points from that trial, and I'll just emphasize that the trial included patients from the age of 6 months to 5 years.
Right. And Candace, there is a question from our audience about how long before you see efficacy of dupilumab, and do you ever combine with steroids for early induction? So I'll take a stab at that question real quickly. And the earliest efficacy that I'll tell my patients is usually around 4 weeks. Like sooner than that, it's sometimes a little bit difficult to really appreciate any differences, and it's important to set expectations for patients. I will sometimes combine induction with oral prednisone to calm them down while I give time for the dupilumab to do its thing. So that's about, I would say, the earliest I see an improvement. Sometimes for patients after their loading dose, they can say, you know what, I felt really good afterwards. But I think it's important to discuss that as well with patients. Any thoughts on that?
I totally agree. I usually tell them after the loading dose that they will feel a difference. It may or may not look like something is happening, but they definitely are going to feel a difference. So I do kind of set the expectations high for the medication, but you're right, definitely after a few dosing sessions, then people usually are definitely can see and feel a difference.
Okay. And there was a question also in the chat about the dosing regimens, and it's important to mention that yes, the dosing regimens between pediatric and adult for dupilumab for atopic dermatitis are different, and for children, it's actually based on the weight of the patient. So it's important to be to recognize that. And there's also that question about long-term data for dupilumab. And I think it's important to also mention that there is a study looking at about 3 years worth of data of actually patients being on this medication long-term, showing no new safety signals and sustained efficacy for those in our audience out there. So let's move on to talking a little bit about post-inflammatory hyperpigmentation, which is the concern of our patient Cecily. Candace, can you talk to us a little bit about treatments for PIH? I know you talked a little bit, there's a case report that you examined, whether or not if dupilumab could improve PIH in patients with atopic dermatitis and skin of color. Can you talk to us a little bit about what are some of the treatment options currently available and also your case report?
Sure. So I think it's a great idea to always be prepared to treat post-inflammatory hyperpigmentation. Of course, we know the number one thing to do is to get the atopic dermatitis under control fully. That's the one thing that can definitely help to prevent further post-inflammatory hyperpigmentation. But also, when the disease is under control, some patients still have post-inflammatory hyperpigmentation. So some of the common treatment approaches after you get the atopic dermatitis under control may include doing topical medications that may include hydroquinone, which is a topical agent that can help to lighten dark spots. For some patients who are interested in more cosmetic treatments, additional cosmetic treatments, there are some lasers that can also help with pigmentation. But really my go-to is going to be to help to treat the underlying condition first, and then protecting the skin so that it doesn't become darker. So sometimes that would include using, protective hats to keep the sun from shining on that area, especially if it's on the face, and then also using moisturizers with sunscreen as well. And then particularly for areas on the face, like the photo shown here, may even benefit from chemical peels as well. So I think those are all great options. And then on the next slide, we can hop into a case that I reported in the literature of a 53-year-old Black male who had a 1-year history of worsening pruritic rash, which is diagnosed as moderate to severe atopic dermatitis. We started the patient on dupilumab, and not only did I notice that the hyperpigmented plaques were getting much better as he did his dupilumab injection, I also noticed that even other areas of his skin began to lighten as well. So it kind of demonstrated two things, in which I point out in the paper. It demonstrated that, yes, definitely that treatment was working for atopic dermatitis, but it also gave us another good take-home point that even if you don't see the atopic dermatitis active in a specific area, that they definitely may have activity that is not clinically perceptible. So definitely we need to listen to our patients and really think about systemic treatment options when it is appropriate for that specific patient.
Right, and Candace, we do have a question about sunscreens for post-inflammatory hyperpigmentation. Any comments on that? And I think that's a very important part of the treatment regimen for PIH. And my particular preference is to have patients use physical, but also tinted sunscreens to protect against the effects of not only ultraviolet light, but also visible light. Which can be tied in. There's increasing evidence to suggest that visible light can tie into worsening skin dyspigmentation. So I will typically go along those lines, physical sunscreen, but also a tinted one. Any thoughts on that?
Yeah, I think with sunscreen, there was just definitely a lot of debate going on about sunscreen. So I really want patients to use the sunscreen that they feel comfortable using, whether that is a physical blocker or a chemical-based sunscreen. Whatever they are comfortable using is the one that I want them to use. Sometimes for patients with skin of color, they can even add a little liquid makeup to the sunscreen to try to just counterbalance the white cast on the skin that can sometimes be caused by more physical sunscreen blockers. So definitely, I tell patients to try the sunscreens out. I give recommendations, and then I just want them to use the one that they can consistently use.
Okay. And then, so Candace, can you talk a little bit about, it looks to be an exciting future for patients with atopic dermatitis. Can you just very briefly mention some of the things that are out there or are going to be hopefully out there in the future for our patients?
Sure, it's an exciting time for atopic dermatitis. And so some of the new targeted treatments are going to target the JAK pathway. So we have JAK1 inhibitors, we have JAK1 and JAK2 inhibitors, we have additional interleukin-13, isolated interleukin-13 inhibitors as well, and even a PDE4 inhibitor coming, hopefully coming out as well. So that these are going to be interesting because they're going to also have different various ways of delivery of these medications. So some oral options, topical creams, in addition to more injections as well. So it is an exciting time for atopic dermatitis, and we look forward to our patients having more and more options to choose from for their moderate to severe disease.
Wonderful, Kendra. So now we're going to be moving on in the last few minutes of our time here together to talk a little bit about long-term management plans for our patients with moderate to severe AD. So let's talk a little bit about, you have the patient, it's the scenario, they're being treated, but there is potentially loss of disease control. So can you talk a little bit about what are some of those factors that can lead to loss of control of their disease?
Sure. So for the contributors to loss of disease may include a plethora of things. So environmental exposures. I know we talked about carpet when Braden, with one of our cases, the Braden case. Also other comorbid conditions, in addition to the inconvenience of applying things and having multiple steps in their regimens for the atopic dermatitis. That can affect adherence to medications. Also, there could be this fear of the adverse events that could perhaps occur, and the thought of that preventing patients from actually consistently treating their disease as well. There could be distrust of the medical establishment, the cost of treatment, lack of access. So we can go on and on about things that may contribute to the loss of disease control.
Perfect.
So one of the important approaches is to really think about managing atopic dermatitis as a team. So multidisciplinary teams play a really crucial role, whether we're talking about physicians and nurses, nurse practitioners, PAs, pharmacists. We all need to come together to really help patients manage their conditions. And Zelma, what are some of your favorite strategies for managing flares?
So when we talk about, management of flares in atopic dermatitis, and I think my first strategy is patient education. I want my patients to be empowered. I want them to understand their condition, and I want them to understand what their treatment is doing. And it takes time. So usually during our first visit together, I will purposely set aside additional time to make sure that we untangle all the ideas that a patient may have about atopic dermatitis, try to get down to what are the basics of this disease, why are we prescribing this treatment regimen, and what are our expectations with treatment. I think it's important to educate our patients that even while on dupilumab, you may still experience a flare. But those flares at the end of the day should be more manageable, right? We should be able to tackle them sooner. So I want them to know what to do in the event of a flare. What should be your eczema action plan? And there are some resources that you can download free of charge from the American Academy of Dermatology for use in clinic. You can create your own resources, which is what I do for my patients. I do also try to refer my patients to patient advocacy groups, such as the National Eczema Association, for them to learn a little bit more, to find that there is a support group out there. But I think education is very critical to help empower those patients, and sort of just very briefly stating, these are the steps that you would take if you have a flare. We'll start with this. If this is not controlled, we'll optimize to this. And when is it that you reach out to me, right? Probably sooner rather than later. And so that's usually my advice for patients. And so before we wrap up, since we're coming towards the end of our program, and we take additional questions, we have a number of great questions in the chat. We're going to go back to our cases, and let's see if we can get the audience responses on the screen.
Okay, we are revisiting our question about Braden from earlier. So our options are listed on the screen. So take a moment to vote again on the same question. Okay, so our graphs show that there has been a little bit of change from when we did the question the first time. So it looks like tacrolimus and topical steroids was a close second. I'm sorry, was the primary selection initially. And then in the second round of asking the same question again, number 5, which was dupilumab, actually became the most selected answer. So I don't know if you want to comment on that, Zelma. So we went from kind of just giving Braden tacrolimus and topical steroids to really thinking about more systemic treatment.
Right. And I think this is, I would agree that this is also probably a good choice, right? It does depend on the patient scenario, but I think it goes to show how the paradigm is changing, how we treat or approach the treatment of patients with atopic dermatitis, not just focusing on treating the acute flares, but can we control the flares long term? And certainly dupilumab is an option for that.
Okay, so let's go to Cecily.
Let's see if our audience can vote. And Candace, I still cannot see the poll, so you might need to help me on that.
Sure. Okay, so for Cecily, in our initial poll, the selected answer, let's see, hold on for a second, was the tacrolimus and the topical steroids. Let's make sure here. Okay, and then in the second, our post quiz, the 50% went with selection number 5, which is dupilumab.
Got it. Okay. So I think it's important to understand, when you look back at Cecily's case, this is a patient that has been dealing with atopic dermatitis on and off, right, throughout her lifetime. And she's been trying to use various options for topical steroids without really good control. Now is struggling with post-inflammatory hyperpigmentation. So certainly dupilumab is an option for her. I mean, you could try managing with topical medications as well, but if you're trying to develop a long-term plan, I would certainly agree that that could be one way to go. Do you have any comments on that?
No, I think that's a great response.
Okay, and so we're going to then move on to what is our SMART goals for this program. So during this program, we really do hope that we're able to, have a frank discussion about what are some of the disparities that we can see in the diagnosis of atopic dermatitis in children and adults with skin of color. We hope that you sort of emphasize that there are clinical features that are very different, particularly, assessing erythema. And we also hope that you had the opportunity to learn about some of the objectives in terms of what tools to use and what are some resources that can help support your patients and their caregivers. I also do want to mention that CME Outfitters does have a dermatology hub with a number of excellent resources for clinicians and patients. And if you'd like to receive CME or continuing education credit for today's program, please complete the post test and you'll be able to download and print your certificate immediately upon completion. So thank you so much again, Candace, for joining me. I do apologize to the audience if we're not able to get to your specific question. There are so many questions out there. And thank you so much